please start answering in the chat box. So we'll take just one minute for each thing, and followed by the, I'll give the answer then and there itself for the sake of, saving time. So this is the first question. A 26-day-old baby boy presents with poor feeding and irritability for the past 1 week. The mother feels that the milk output is adequate and feeding is adequate. On presentation, he has severe dehydration and no signs of respiratory distress. Further lab examination reveals serum sodium of 104, potassium of 7.3, glucose is 35, has a pH of 7.12, PCO2 of 36, bicarbonate of 14 milliequivalents per liter, and a negative sepsis screen. So what is the diagnosis? Name the investigation of choice, 2 investigations of choice. What is the emergency medication which needs to be started? Can you all answer, please? Yeah, I see some answers over there. Okay, so this is a classical presentation of salt wasting type of congenital adrenal hyperplasia. Yeah. So the investigations to be sent mainly are, along with the basic investigations like renal function test, blood gas, glucose. So the other 2 main investigations are 17, as you all rightly pointed out there, 17-hydroxyprogesterone and cortisol needs to be sent immediately. And this baby needs to be started on stress dose of hydrocortisone, which is 100 milligram per meter square. So in the emergency room, when you're starting a stress dose of hydrocortisone, you don't need to give fludrocortisone at that time. Once we are tapering the hydrocortisone, then, fludrocortisone need to be added. Okay, so we'll go to second one. So this is a neonate brought to the triage on day 20 of life with a history of poor feeding and lethargy for the last 2 to 3 days. On examination, peripheral pulses are feeble and capillary refill time is 4 seconds. ECG of the neonate is shown below. So please have a look at the ECG. So questions are, what is the diagnosis, and name the 2 treatments of choice and the dose. So what is the diagnosis? Name the 2 treatments of choice and the dose. Can we have the answers, please? So look into the case scenario. So baby has a history of poor feeding, lethargy, and the pulses are weak and capillary refill time is 4 seconds. So what would be the treatment of choice? Okay, so we'll look at the answers. So as you all rightly pointed out, it is supraventricular tachycardia, which is a narrow complex tachycardia with absent P wave, which was there. So as this baby is in, shock, the main treatment of choice is synchronized cardioversion, 0.5 joules per kilogram. The other treatment is adenosine, 0.1 milligram per kilogram, followed by a rapid bolus of normal saline, 3 ml. Okay, so we'll go to the third question. So we have a 4-day-old neonate who presented with hypoxic ischemic encephalopathy at admission and has completed the cooling. So, and is noticed to have this skin lesion at the back of the thighs as shown in the picture by day 4 to day 5. So what is the diagnosis? Name the 2 risk factors for this and name 1 related complication to this condition. What is the diagnosis? 2 risk factors and 1 related complication. Can we have some more answers, please? There are 3 parts to the question? Okay. Yeah, excellent. Okay. So yes, the diagnosis is subcutaneous fat necrosis. The risk factors are some of the common risk factors. Any two would have been okay. Any birth trauma, asphyxia at birth, meconium aspiration, therapeutic cooling, all these are risk factors for subcutaneous fat necrosis. And a common complication associated is hypercalcemia. Most of the time, it is just conservative management, but sometimes hypercalcemia may need active management. We'll go to the next question. Okay. So look at this fundal picture from the ROP screening. What is the ROP stage in this picture? Name the indications for laser treatment. What is the stage of ROP? And name the indications for laser. You can write why it is that stage as well. Very good. I see more answers for this question. Name the indications for laser. 1 or 2 indications for laser. Okay. Okay. So that is, as you all said, it is stage 2 ROP because we can see the ridge here, so which is arising from the demarcation line. If the ridge has a fibrovascular proliferation, then it will be stage 3 ROP. So any type 1 ROP, as rightly pointed out by few of you, so that's the indication for treatment for laser. So yes, type 1 ROP or aggressive ROP. So type 1 would be any of these. That is zone 1 any stage with plus, zone 1 stage 3 without plus, and zone 2 stage 2 to 3 with plus, including aggressive posterior ROP. Okay, I hope it's clear. We'll move to the next one. So number 5. So we have a 2.8 kilos term baby who is vaginally born. No risk factors for sepsis. He has weak cry and irregular breathing at birth. He needs ventilation for 1 week. X-ray chest and sepsis screen are reported as normal. And he's discharged on day 14 with mild tachypnea. At 6 weeks of life, he is alert, smiles, has tongue fasciculation and weak cry. Neurological assessment was significant for hypotonia of the upper limbs more than the lower limbs and depressed tendon reflexes. What is the probable diagnosis? 2 differential diagnoses and 1 test for confirmation. It has a key point in the question which, kind of gives away the answer. Yes, most of you are answering. So differential diagnosis, most of you have answered the probable diagnosis. Can we have some differential diagnosis? Okay, confirmatory would be genetic workup. Yeah, very good. So it is type 1 spinal muscular atrophy or SMA. Other differential diagnoses most commonly are, myotonic dystrophy and myopathies, phrenic nerve injuries, and diaphragmatic paralysis. Confirmatory would be genetic testing. Along with that, other supportive tests can also be done. Okay. So number 6, a full-term male infant is born to a 32-year-old gravida to para-1 woman by cesarean section for non-reassuring fetal heart rate and severe oligohydramnios. Mother has group B streptococcal infection. After an uneventful delivery, the baby was shifted to NICU and started on CPAP. On day 15 of life, he was noticed to be irritable with bulging fontanelles, and lumbar puncture was suggestive of meningitis. Antibiotics was started, and an ultrasound of the head or brain was done, which shows the picture below. So we can see this is the ultrasound finding. So have a look at the ultrasound finding, what it is showing. We have two images here. So the question is, what is the view of the ultrasound in pic A and B? What does it show? What's the diagnosis? What is the next step in the management? So you have two sections, A and B. So what is the view of the ultrasound? And what does it show? What is the next step in the management? Can we have some more answers, please? So diagnosis and next step in the management. Okay, so some of you have answered correctly. So section A is the coronal view and section B is the sagittal view. Antibiotics has already been started. So it shows enlarged ventricles with severe hydrocephalus. Excellent. Many of you have answered. So the next step would be, first is to monitor this head circumference serially and plot it on the chart and have a trend of the head circumference. As you all rightly said, serial lumbar puncture, and the other options are to get a ventricular drainage as an external ventricular drain or a reservoir, and the permanent option later would be a VP shunt if it was still persisting. So we'll go to the next one. So look at the image. What are the three findings in this chest X-ray? What is the diagnosis? Name two poor prognostic indicators of this condition. I need three findings of the chest X-ray. So you're all giving the diagnosis. Yes. Yeah, some of you are answering very well. Very good. Yeah, some of you are giving the poor prognostic indicators. Excellent. Okay, so we'll go see the answer. So the three findings are presence of bowel loops within the chest cavity, mediastinal shift to the right, most of you told, and also the endotracheal tube is in a deep position. So normal position is between T2 to T3. So the diagnosis is left congenital diaphragmatic hernia. Poor prognostic indicators, any two could have been given. Present, you have already given some of them. Presence of liver in the thorax, lung to head ratio less than 1. Yes, severe pulmonary hyperplasia, which is shown as fetal lung volume less than 25% of expected. Any right-sided CDH is more problematic. And also, if it is associated with congenital or chromosomal anomalies, they are known to have poor prognosis. Let's go to number 8. You've been called to counsel the parents who are expecting a 25-week delivery in a tertiary intensive neonatal unit. So you are equipped. The expected weight of the neonate is 800 grams and antenatal steroids have been given. You have counseled them that there is no chance of improvement for the baby and to opt for comfort care for this baby. However, the parents are adamant and they want full resuscitation and NICU care to be done for this baby. So which ethical principle, is at question here, because we have a conflict between what we are saying and what the parent is opting for. Can you name the 4 basic ethical principles? Any of you, please? So which ethical principle is that question here? And the regular, 4 basic ethical principles. Yeah, the parental request, what is it called? Shall we move ahead? I don't see much answers to this. So that is called autonomy. So that is, we have to respect the patient's right to choose the treatment. So along with autonomy, the other principles are beneficence, which is whatever we do, we have to keep the patient's best interest as the center of it. Non-maleficence is do no harm, and justice, that is treat all patients fairly and equally. These are the 4 basic ethical principles. We'll go to OSCE number 9. Name the 4 steps of a QI project or a quality improvement project. This is pretty easy. So plan, do, study, act. Can we expand it a bit more? We're almost on time. Another 2 minutes. That's it. Anyone else? Yeah. So what do we do in planning? Do is what, study is what, and act is what. Okay. So plan stage is identifying the problem and writing an aim statement. Very good. Yeah, you were about to write. Do is collecting the data. Study is once you collect the data, you compare the results and analyze. And act is based on the results and the analysis what you have, then you make the recommendation whether you want to accept the changes what you introduced, whether you want to implement or you want to go to the next PDSA cycle. Okay. So with this, we'll go to the last question. So in a study to evaluate the safety and efficacy of antenatal glucocorticoids in women in low resource countries, neonatal death occurred in 270 out of 1,500 infants in the dexamethasone group and 330 of 1,500 infants in the placebo group. So there are 2 groups. One received dexamethasone, the other received placebo. In the dexamethasone group, there were 270 deaths, 1,500 infants. And in the other group, placebo, 330 deaths out of 1,500 infants. So I want you to calculate the relative risk and what is the number needed to treat. So we'll give a couple minutes for people to calculate. Calculate the relative risk and the number needed to treat. If you can at least post, answer, how do you calculate relative risk and number needed to treat? That itself, it will be good. So how do you calculate relative risk and number needed to treat? So you need to form a 2x2 table first. Excellent. Okay, so number needed to treat. Okay, can we have some more answers? Because this includes calculation. I'll give another 1 more minute for people to do it. So 10:10 we will be able to conclude. I see some answers. Very good. Can some more people answer? Try. Okay, so we'll look into the answer about how to calculate. So the first step, as I said, is we need to form a 2 by 2 table. So at the top will be the disease. So here, we are looking at death versus no death. And then on your left-hand side will be the intervention versus the placebo. Excellent, whoever answered the number needed to treat there. So top will be the disease versus no disease. And then on the left-hand side will be the intervention and the placebo. So if you've got this, then you will get the next steps. So relative risk is exposure event rate to the control event rate. That is the event rate or the incidence in the exposed group to the incidence or the event rate in the control group. So this is the exposure group, dexamethasone group. So the incidence here is 270 deaths out of a total of 1,500. So that will be a exposure event rate. And in the placebo group, that is the control event rate, 330 deaths out of 1,500. Okay, so that's the exposure event rate, or the incidence in the exposed group is 0.18, and incidence in the control group, that is control event rate, is 0.22. So relative risk is incidence in the exposed to the incidence in the control group. So we get 0.8. Many of you answered. Excellent. So next question was to calculate the number needed to treat. To know the number needed to treat, you need to know how to calculate the absolute risk reduction. Absolute risk reduction is a difference between the control and the incidence in the control versus the exposed group. So that is 0.22 minus 0.18, which is 0.04. This is absolute risk reduction. Inverse of this is number needed to treat. So number needed to treat is 1 upon absolute risk reduction. So I'm very happy that many of you have answered. So the absolute risk reduction is 25. That means we need to treat 25 neonates to see an improvement in the death or no death in 1. Okay, I think with that we are done, Dr. Nalina.
Thank you, ma'am. Thank you for the both the session Osce and the case taking session also. I request you to send the score sheet of Dr. Shaukat, ma'am.
Yeah,
Mm-mm.
thank you.
Thank you. Anyone has any doubt, they can put it in the chat box. We will wait for 30 seconds to 1 minute. After that, we'll conclude this today's session. I think there is no doubts. I think, ma'am. No, I cannot see any messages in the chat box.
Yeah.
Thank you, ma'am. Thank